diagnosis and questions. So that's how I think some of the very important, and because we have 2 hours in the exam, you will not have much time, only 15 minutes. So you will be made to cut short everything. But here we can actually discuss in detail about the whole thing of diabetes. So first, Kaushik or Ramanathan, you just read your history and examination, then we will go into discussion.
Yes, sir.
Okay, sir. Patient details. Mr. Rajendran, 60-year-old male, resident of Kadalur. Occupation is a farmer. Chief complaints. Patient presented to the hospital with the complaints of wound in the right foot for past 2 weeks. Now planned to undergo wound debridement. History of presenting illness. Patient was apparently normal 2 weeks ago. He sustained trauma to his right foot while working in his farm. Thrown brick injury, which was managed at home by washing in running water. Patient noticed a swelling in the right foot after trauma, which developed it into a wound, sudden in onset, non-progressive in nature, associated with serious discharge. Initially, now purulent discharge was present from the wound. Complaint of fever, mild grade, continuous fever, not associated with chills and rigors, no diurnal variations. Patient is a known case of diabetic for past 5 years on regular treatment with one oral hypoglycemic drug, tablet metformin 500 mg plus glycemic 2 mg combination, taken twice daily before food. Diagnosis of diabetes was insidious during evaluation of tiredness and fatigue. No history of hospital admissions for diabetes, no history of chest pain, difficulty in breathing, weakness of limbs, decreased urinary output, visual disturbances, altered sensations in the foot. Past history, med score 4 to 7, no history of no other comorbidities, no history of previous surgery or anesthesia exposure, no history of blood transfusions, allergies. Personal history, patient consumes mixed diet, vegetarian and non-vegetarian diet. Patient has no recent changes in bowel and bladder habits. Not a smoker, not an alcoholic. Patient sleeps well. Family history, no history of diabetes, hypertension, cancer history in the family. No other significant family history.
Yeah. Just wanted to close the door. Right. Continue.
On examination, the general examination, patient is comfortably seated during examination. Patient is conscious, oriented, and alert. He's a moderately built male. Temperature is he's afebrile. Height of 170 centimeter, weight of 60 kg, BMI of 20.7 kilogram per square meter. There is no evidence, no signs of pallor, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Vitals. The pulse rate of 90 per minute, regular in rhythm, no specific character, all peripheral pulses were felt equally. Blood pressure 130 by 70 millimeters of mercury, measured in the left upper arm in sitting position. SpO2 of 96% in room air, respiratory rate of 18 per minute, regular, abdominal thoracic breathing. Temperature was afebrile. Airway examination, normal facial symmetry, interincisor gap of 5 centimeter, Lambert class 2, neck movements were normal, mentohyoid distance greater than 6 centimeter, upper lip bite test class 1, and trachea was felt in the midline. Palm print sign was done, and it was grade 0. That is all interpharyngeal spaces, all interpharyngeals were able to be visualized. Systemic examination, CVS. Systemic examination was normal, so there was no finding.
Okay. But in that, you should, tell in brief about CNS examination, because that is very important, especially to rule out peripheral neuropathy. You'll have to talk about that in slightly more detail, not like, normal.
Okay, sir. Yes.
Okay.
We have change.
Okay, right. So tests for autonomic neuropathy, you will not be able to do it. You require a continuous ECG monitoring for that. And you require special equipment for Valsalva and also special equipment for sustained hand grip. So you cannot do, you have written it, but you cannot do these things in exams. So only in what you can do is standing blood pressure test. That's all.
Okay, sir.
With that. most of the things you will have to get it from history, whether the autonomic neuropathy is there or not. Okay, just tell about the final,
Summary.
the diagnosis of the patient, or local examination is very important. Yes, tell about local examination.
The local examination of the right foot. There is a 5 into 4 centimeter wound in the plantar aspect of the foot with yellow slough present. There is a multiple spots of black discoloration noted. Warmth is present on palpation, and purulent discharge is seen. Rest of the right lower limb, there is no discoloration. The peripheral pulses were felt, and no dilated veins were noted. The opposite limb examination was normal. Summary: a 60-year-old male patient who is a known diabetic for the past 5 years on treatment with oral hypoglycemic drug, with no signs of microvascular or macrovascular complications related to diabetes, came with complaints of wound in the plantar aspect of the right foot for 2 weeks duration, associated with purulent discharge and low-grade continuous fever, and is posted to undergo wound debridement.
Okay, so that is your, the presentation. So, what are your positive things in the history and positive findings in the examination? If you can just tell in a nutshell. Only positive.
Positive history was that he had sustained trauma, sir.
So he's a known diabetic. So
He's a known diabetic.
start with he's a known diabetic for the past 5 years.
Yes, on oral hypoglycemic drug, sir. Metformin plus glibenclamide combination.
Yeah.
He takes it twice daily before food. He has not had any hospital admissions related to diabetes. There is no history of hypoglycemic episodes or anything like that, sir.
Okay.
He has history of chronic injury, sir.
Okay. So no history of acute complications, no history of delayed complications of diabetes, history-wise.
Yes, sir.
Isn't it? Okay. Then
on examination, the local examination.
Ulcer was present, sir. Local examination.
body mass index is almost near normal.
Normal,
sir.
Between 20 to 23, it is near normal. He is not obese. Majority of these patients will be obese, so that is not there. Okay, so other things are almost normal. That even standing blood pressure is also, there is not much of a difference. So systemic examination is also normal. So of course, he has got a infected wound on the plantar aspect of his foot. So these are your positive, because I told you in the last time also that whenever you are presenting a short case, after you present, you keep mentioning about what are the positive findings in the history and what are the positive findings in your examination. You write down separately at the end, because invariably you will be asked about by the examiner about these things. Important positive findings in the history and examination, or they may not ask you to present at all. They may just ask you about these important findings, because time will be very short, only 15 minutes. They'll not be able to ask you to present the whole history and examination. Okay, in the history, one thing I wanted you should have asked is whether there is any pain in the ulcer. You have not written there whether the patient had any pain in the ulcer, or even when you are examining the ulcer, whether it was the edges or the ulcer was painful or not, tenderness was there or not. Because why this is important to ask about pain in the ulcer?
If the patient had developed peripheral neuropathy, then patient would probably not feel any pain, sir.
Yeah, isn't it? So that becomes very important, and that can be a cause for his chronicity of the ulcer. Isn't it? What are the causes why the diabetic foot, we always, are very popular. It's a chronic ulcer in the foot, isn't it? Why it becomes a chronic ulcer in diabetic patients? What are the reasons?
Due to the peripheral vascular disease, sir, they're more prone for accelerated atherosclerosis, which will cause the peripheral vascular disease, which will cause a non-healing ulcer, sir.
No, you mean to say that there is decreased blood supply to that area where the ulcer was there, so that decreased blood supply means decreased oxygenation of the area. So decreased oxygenation means delayed wound healing.
Yes, sir.
That is what healing. That is one of the reasons. One reason. Another reason, already you said that there can be peripheral neuropathy is always there in these patients, and because of that, they don't feel the pain. Once they don't feel the pain, they may neglect the wound because the pain is a protective mechanism, isn't it? Whenever you have pain, you give more importance to that area of pain, and then you go to the doctor, get it treated. If they don't have pain, they may neglect it. Third thing is there can be, because there is no pain, there can be repeated injuries to the same area. Whenever there is repeated injuries to the same area, the ulcer cannot heal, isn't it? The fourth important consideration always in diabetic patients is these patients have decreased, chemotaxis. Chemotaxis is, rushing of, leukocytes to the area where there is an injury and, to prevent infection. So there will be a decreased chemotaxis or inhibited chemotaxis. The next thing is the phagocytosis is also inhibited. That means, the phagocytes will not be able to, kill the bacteria or viruses, whatever the infective agents there. So that is another reason why they can have prolonged or delay in wound healing. And the most important thing, you must have seen that superficial ulcers heal rapidly in these patients, but deep ulcers will not heal. And why deep ulcers will not heal in these patients is mainly because they have a defect in collagen formation.
Normal.
Collagen is not easily formed in them. So because of that, collagen formation is very important whenever there is a dermal injury, deep injury is there. And for healing, collagen has to form and then produce a scar there. So because the collagen formation is defective, so that is another reason why the wounds will not heal. The final thing is, they have an immunosuppression. They cannot fight the infection. So these are all because, this is very important question. Invariably, you will be asked in the exam why these patients develop a chronic non-healing ulcer. It is called as a chronic non-healing ulcer. And when do you say it's a chronic non-healing ulcer? After how many days of treatment? If it still doesn't heal, then you call it as a chronic non-healing ulcer.
More than 3 weeks, sir.
More than 4 weeks. That is usually the cutoff point. If the ulcer persists for more than 4 weeks, in spite of treatment, it is not that if you don't treat, definitely many of the ulcers can persist even after 4 weeks. But in spite of treatment, if the ulcer persists for more than 4 weeks, you call it as chronic non-healing ulcers. So just the differential diagnosis, of course, here there is a definite injury is there. And some of the differential diagnosis for a chronic non-healing ulcers are what? Other than diabetic ulcer.
Varicose vein causing venous ulcers.
Venous ulcers, sir.
Venous ulcers, varicose veins. Okay, then?
Peripheral vascular disease.
No, that is because of diabetes, already I've said. One of the causes. Tubercular ulcers and malignant ulcers. So these are the other chronic non-healing ulcers. One is diabetic ulcers. Second thing is because of the varicose veins and stagnation of blood that can produce. Third is tubercular. And fourth is more important is the malignancy. And you know that varicose ulcers will not occur at the foot where the patient has had. Isn't it? Plantar aspect, varicose ulcers are not seen. Mainly the medial aspect or the lower part of the leg, usually you can have. So, but tubercular ulcers and malignant ulcers can occur in the plantar aspect of the foot. So, how to differentiate these other than diabetic foot? Because diabetic patients are also prone for tuberculosis because of immunosuppression. And he's an old man, more than 60 years. Definitely, he is prone for even malignancy. So, how do you differentiate? All are chronic non-healing ulcers. Just you may be asked about this particular question. By examination, how can you know whether it is a tubercular ulcer or
Sir,
malignant ulcers?
based on the ulcer shape and depth,
Okay, ulcer.
can classify.
The edges of the ulcer.
Yes, sir.
Most important is the edges of the ulcer and the floor of the ulcer. In tubercular ulcer, how will be the edges?
Sloping edges.
They are called as undermined edges. So underneath the edges, there will be ulcer will be there. So mined edges. Whereas malignant ulcers,
Punched out edges.
huh?
Punched out.
No. How will be the averted edges? Edges will be averted. They are not undermined, they are averted. Plus, the ulcer may be fixed to the deep tissues. You will not be able to move. So why I asked you these things is when you are examining, you have to tell about these things. Ulcer examination, how are the edges? How is the floor? Whether it is fixed to the deeper tissues or it can be moved. So this is one thing you have to ask. Of course, whether it is painful or not, that is very important just for us to know whether there is how much of peripheral neuropathy is there or not. Because again, if it is not so much painful, so your anesthesia also you can vary it, isn't it? You suppose if the patient doesn't have any pain at all and no sensation in the foot. So for wound debridement at all, why should you give any anesthesia as such? You may not be able to, you just can give a monitored anesthesia care if he doesn't have any sensation. So absolutely no pain. So that is why you should, even in the history only, should always ask whether there is any pain in the whatever the wound he has. That is one thing. And second thing is, so when he has been admitted to the hospital, that is another important question you have to ask. When he has been admitted to the hospital now?
On that day.
That day only. So he would not be posted immediately, of course, for wound debridement. So they would like to optimize his sugars and other investigations they would be doing, isn't it? So you'll have to ask, once he is admitted to the hospital, they would have started him on with other medications. So what other medications he could be on?
They could have started antibiotics, sir.
Antibiotics, very important. So he could be on antibiotics. And how about he is on oral hypoglycemics, isn't it? You said that he is on metformin and glibenclamide. So would they continue to use the same thing, or would they like to change him to an insulin regime? Probably.
They would change to an insulin regime.
So this becomes very important once the patient has been admitted at least about 3-4 days before, and he has been now posted for wound debridement or whatever the procedure they want to do. So then you have to ask about these other things. And one very important thing, all we know already, that these patients invariably will have macroangiopathic problems like coronary artery disease, and they will have hypertension. Coronary artery disease are very common, and they might have already had some revascularization procedure as well. So they can be on multiple drug therapies. Of course, your patient is not on any multiple drug therapy, but you can't have the same patient for your practical exam. He can be a different patient who might have had a revascularization procedure for his coronary artery disease, or even otherwise also he may be on multiple drugs for his coronary artery disease and his hypertension. So these things you will have to really inquire into. And regarding the medication history, you will have to present these things. And one more very important thing is, invariably all diabetic patients are considered to be having ischemic heart disease unless it is proved otherwise by getting an angio done, coronary angio done. Till then, you consider them, because 100% of these patients will have atherosclerotic coronary artery disease will be there. So you'll have to slightly go into details about coronary artery disease in these patients. And already in previous discussions, I was telling you that some of these patients with autonomic neuropathy, they may not present with angina, isn't it? Because they may have silent angina or silent ischemia. Silent ischemia is very common. Then you go for angina equivalent. Previously, I told about angina equivalent. When you call it as an angina equivalent, what do you call it as? What is angina equivalent? When the patients have autonomic neuropathy, they are not presenting with any kind of chest pain, but you cannot rule out ischemic heart disease. So you have to ask something else. Dyspnea and the grading of dyspnea is an important thing in patients with autonomic neuropathy. You call it as angina equivalent.
Yes.
So they can present only with dyspnea. That is another very important thing which you have to look into. And the other thing is, you have to ask about his blood sugar control. He was on oral hypoglycemic. It is not sufficient enough just to say that he was on oral hypoglycemics. Was his blood sugar under control or not during these 5 years? Because he has been diagnosed 5 years back, isn't it? So after that, so was it under control? How frequently he was getting his blood sugar tested? So this briefly you should ask, even though it's a short case. Why it is important to know whether the blood sugar were under control or they were not under control before. Why it's important to know.
Well, if the patient had a well-controlled diabetes, then the probability of him developing complications would be he would develop it much later. Sir.
No, there are two kinds of complications, delayed complications. This is the microangiopathy, which can be postponed or prevented among them.
The macrovascular complications.
Macrovascular complications cannot be prevented. They can be, slightly postponed. That's all. You just cannot. That's why I told you, every diabetic should be considered as having, atherosclerosis, coronary artery disease. Whereas microangiopathic lesions, either they can be prevented totally if he has got a good control, or even if they have in the early stages, they can be reversed once he has a very good control of his diabetic state. So that is how, microangiopathic lesions definitely can be prevented or can be reversed if they are in the early stage. So that is why the control becomes very, very important, how good his diabetes was under control. So this you can only get from the history, or in the investigation, definitely you can get HbA1c, you can get whether he was having a good control or a poor control. But in the examination, you will not get any HbA1c, that investigation report will not be there. So only by history, you'll have to assess whether it was good control or poor control. So you have to ask him how frequently he was getting his blood sugars tested. So many of them would have, they just will not just keep on taking. They'll be going for some other problems, then the blood sugars will be tested, or even the physician would have asked them to get it tested at least once in three months or 6 months or so. So this history becomes important. So this history you have not asked. So you make it a point to ask this in the exam. So that becomes another very important history. So one more history I was telling you is about the autonomic neuropathy. Because autonomic neuropathy by examination, it is very difficult to find out with routine examination, because then you have to have autonomic neuropathy tests, especially CAN test, that is cardiac autonomic neuropathy test, that is by Clark and Ewing's test. So only by doing those tests, you can be 100% sure whether the patient has got only parasympathetic autonomic neuropathy or both parasympathetic and sympathetic autonomic neuropathy. Since you will not be able to do these tests, so you have to go with the history again. So with, autonomic neuropathy. So what history you would be, because you have not mentioned those history, that's the reason why I wanted to ask you. Well, how do you elicit the autonomic neuropathy history-wise?
Sir, a patient may have
No, individual system-wise, you can always take the history.
Okay,
like cardiac.
In cardiovascular system, patient may have a resting tachycardia will be there, sir.
No, resting tachycardia is examination. History, we are asking. In the history, how do you know whether cardiovascular, involvement of autonomic neuropathy is there or not?
Sir, palpitations, shortness of breath.
So easy fatigability, exercise intolerance. Easy fatigability and exercise intolerance is very common if the patient has a cardiac autonomic neuropathy. Why easy fatigability or exercise intolerance will be there in these patients with autonomic neuropathy?
Because of
they will not be able to increase their cardiac output.
Why they cannot increase their cardiac output? What actually increases the cardiac output initially?
The baroreceptor
mechanism.
No. You have stroke volume and heart rate, isn't it, to increase cardiac output. So They have to increase either one of them or both
Yes,
Yes,
sir.
sir.
to meet the increased oxygen demand when somebody exercises.
Yes, sir.
So
Initially, heart rate
not increase the cardiac output.
Heart rate
increases the cardiac
Yeah,
output.
there is a fixed cardiac fixed heart rate is there because of autonomic neuropathy. Because heart rate can be responded only because of the activity of the sympathetic and parasympathetic systems, isn't
Yes,
it?
sir.
Sympathetic is the predominant thing, but the sympathetic is equally important to increase the heart rate. So that the suppression of the parasympathetic and increase in the sympathetic activity will increase the heart rate. Thereby, there will be an increase in cardiac output that can meet the increased oxygen requirements, isn't it? So here, because they cannot increase their heart rate, they cannot increase their cardiac output. And if they cannot increase their cardiac output, they'll have exercise intolerance. They'll have easy fatigability. That is one important thing. Second important thing is, for example, now a patient was having angina, now suddenly angina is not there. But the same activity which he was not able to do before, and he was developing angina, now he cannot even do that activity. He develops dyspnea. That shows that he is getting a silent ischemia because of again sympathetic fibers are the ones. Last time I had asked which fibers carry the pain sensation from the heart. It is T1 to T4, the sympathetic ganglia. There it is from these are the fibers which relay in these ganglia and then taken to the spinal cord and further. So because sympathetic autonomic neuropathy is there, there will be silent ischemia will be there. So patient will not feel the pain, but he'll have because ischemia will produce a sudden severe decrease in the cardiac output. So the patient will develop dyspnea. So that which is we call it as an angina equivalent. So this can be there. And third very important thing history you'll have to ask is palpitations. Because dysrhythmias are very common with autonomic neuropathy. And any kind of dysrhythmia can occur, even malignant ventricular tachycardia, ventricular fibrillation can occur, which can produce sudden cardiac death. SCD is very common. That is the reason why SCD is very common. So, when you are presenting, or you just say that there is no history of autonomic neuropathy. So let the examiner ask you, like I'm asking you. So what history you would have taken? So then you would have said, okay, cardiovascular system, if it is affected, this is the history. Okay, coming to gastrointestinal autonomic neuropathy. So what history you would be asking?
Patient may have delayed gastric emptying, sir.
No, delayed gastric emptying is not a symptom. What symptoms he'll come out with because of the delayed gastric emptying?
Constipation, sir.
And satiety will be
Constipation is afterwards. Constipation is not because of delayed gastric emptying. They develop. So which particular autonomic nervous system, which part of the autonomic nervous system gets affected first? Is it parasympathetic or sympathetic?
Sympathetic, sir.
No, it is always parasympathetic. The first affected is parasympathetic. Why parasympathetic again? Why not sympathetic? I'll give you a clue. The long fibers, nerve fibers are affected first. The short fibers get affected later. Which are actually the longest autonomic nerve is which one?
vagus, sir.
Vagus, sir.
Isn't it? Longer the nerve. It is mainly because of vasa nervosum. Vasa nervosum get affected. That the vascular supply of these nerves get affected because of the microangiopathy, because it's a microangiopathic lesion. So the smaller vessels get affected, and as the nerve is a longer one, more chances that it get affected earlier. So it is always the parasympathetic gets affected. What is the effect of parasympathetic blockade that occurs because of the autonomic neuropathy on the gastric motility and motility of the intestines?
There is
Decreases gastric motility.
Decreased gastric, because parasympathetic is the one which increases the motility. That is why they have constipation first. Later, when sympathetic is also affected, now there is no parasympathetic or sympathetic, no supply to the GI tract, so they go in for diarrhea. Okay, and other important thing is they can also have nausea, vomiting increased. That is because the dysmotility of the esophagus and lower esophageal sphincter tone is also decreased. So these symptoms are very important for us. Why these symptoms are important for us? Gastric autonomic neuropathy.
Because when these are affected, we'll be expecting delayed gastric emptying, and we have to prepare for rapid sequencing.
Yeah, full stomach. So you have to consider them as full stomach and you have to take care. So that is the idea. So what about the genitourinary system autonomic neuropathy? What symptoms you can have?
Loss of bowel and bladder control.
So genitourinary.
Erectile dysfunction and retrograde ejaculation.
Dysfunction can be there. Okay, one.
Retrograde ejaculation.
Okay.
And sexual dysfunction in females.
Okay.
And nephrogenic bladder, sir.
Neurogenic bladder.
Neurogenic bladder.
Yeah, neurogenic bladder can occur so that, they don't feel the sensation of fullness of the bladder. The bladder may be distended, they may not feel it. So incontinence or retention. Overflow incontinence can occur. Retention is very common. Because of retention, what they are prone for?
UTIs.
Repeated urinary tract
infections,
including, pyelonephritis. So this one you have to ask about. Is there any history of repeated urinary tract infections, including very severe infections like pyelonephritis? So that is very, very important as far as genitourinary autonomic nervous system is concerned. Now coming to the metabolic autonomic neuropathy. What symptoms they can have? Metabolic autonomic neuropathy. Especially the hypoglycemia, unawareness and unresponsiveness to hypoglycemia. This is mainly because of the metabolic autonomic neuropathy that occurs. Because whenever hypoglycemia occurs, so they'll have symptoms of adrenergic symptoms and neuroglycopenic symptoms. So the adrenergic symptoms are the first one. We'll discuss it in detail later. So the adrenergic symptoms are because of sympathetic system stimulation, isn't it? Because whenever it's a stress. Any hypoglycemia is a stress. So immediately sympathetic system gets activated. So they'll have all the adrenergic symptoms will be there. And this will not occur because there is a sympathetic blockade is there. Autonomic neuropathy is there, sympathetic autonomic neuropathy. So they'll not have symptoms. Though directly they go in for probably neuroglycopenia and they may even go for coma and, she's convulsions and all those. So that is very important. You will have to ask. This is called as unawareness of hypoglycemia. And the second thing is, whenever hypoglycemia occurs, they'll respond. Body will respond, isn't it? So because it is a stress, immediately cortisol is released, more amount of cortisol. In turn, it releases catecholamines, growth hormone, glucagon. All these will try to increase the blood glucose level. It is what is called responsiveness to hypoglycemia. So this response depends on the intact autonomic nervous system. Because there is autonomic neuropathy is there, they may not respond. So this is what is very important. Again, metabolic autonomic neuropathy. That means the unawareness of hypoglycemia and unresponsiveness. And it is again important for us because when the history of unawareness as far as hypoglycemia is concerned, even if you have given a regional anesthesia, they may go in for hypoglycemia and they may not come out with symptoms. And you may think that everything is all right. So that is why unless you go for frequent blood glucose monitoring, you will not know, even though the patient is awake, whether he is going in for hypoglycemia or not. So that is the importance of knowing this metabolic autonomic neuropathy. So one more is the Sudomotor autonomic neuropathy. What are the effects of Sudomotor system autonomic neuropathy?
Dryness of skin, anhidrosis.
Yeah, mainly the sweating, dyshydrosis, not anhidrosis. There can be dyshydrosis. There can be more increased sweating or may not be any sweating at all. This is called as dyshydrosis. And very important is a gustatory
sweating.
If they eat anything, they start sweating too much, many times. And why you have to know about this particular thing? About about Sudomotor autonomic neuropathy as anesthesiologist. they are both prone for hypo and hyperthermia.
Hypo and hypothermia.
Intraoperatively. Anything can occur. They can even go for hyperthermia or even hypothermia, and hypothermia is more common. So that is, that is why, you can ask all these symptoms you should be asking. You just, note down all these symptoms, and one by one, you can just ask and then know whether it is there or not there. So then, when you present, you can always say that, I've asked all these symptoms of autonomic neuropathy and found they are not there. Okay, so that is why, you have to take a detailed history regarding autonomic neuropathy, just about individual systems and whether they are involved or not involved. So if one system is involved, invariably other systems are involved. And one more thing about this autonomic neuropathy, invariably when I have autonomic neuropathy, they'll also have peripheral neuropathy, they may have nephropathy, they may have even retinopathy. They always, majority of the times, go together. Only a single microvascular lesion will not occur because all the smaller vessels are involved, isn't it? So that is how it is so important to ask about autonomic neuropathy. Plus, you have asked about any sensation, loss of sensation in the foot you have asked. So not only foot, you can ask about, what sort of a neuropathy they'll develop, the peripheral neuropathy.
Clown starting type of peripheral neuropathy.
What do you call that actually? Because there are 3 types of neuropathy they can develop.
Sensory motor.
One is peripheral neuropathy, another is mononeuropathy, third is mononeuropathy multiplex. These are the different types of somatic neuropathy. This is a somatic neuropathy. It is not autonomic neuropathy. It is a somatic neuropathy. They can have a mononeuropathy. They can have individual nerves get involved. Like ulnar nerve, they have only one ulnar nerve might have been involved. Or they may have single cranial nerves get involved. Or they may have mononeuropathic multiplex. That means multiple mononeurons, that is single nerves, may be affected. It is not peripheral neuropathy. It is a somatic neuropathy which can be there. This also you will have to inquire into. Is there any individual cranial nerve is involved or individual peripheral nerves are involved? Or majority of the times, what is more common in this somatic neuropathy is symmetrical bilateral peripheral neuropathy. It is always symmetrical. It is bilateral. It is same in both the things, whether it is right foot or left foot, and peripheral neuropathy. And this is, as you are talking about, it's a glove and stocking type of peripheral neuropathy. So it is always better to ask, and this you can examine also.
Okay,
and that's why I told you in your examination, this should be a separate thing regarding the peripheral neuropathy, because the 2 important things about peripheral neuropathy examination properly is, one is, that medico-legal problem. Because invariably, majority of these patients, you would be going in for what kind of anesthesia?
Neuraxial or peripheral nerve block.
Yes, sir.
Yeah,
Spinal
isn't it?
anesthesia.
You will go for regional anesthesia. So regional anesthesia, we know that the rare complication can be, neuronal damage is a rare complication.
Yes, sir.
So if you have not documented these things before, the patient, if he has already has these problems and they will be there in the postoperative period also, then the postoperatively, the patient may go to the court of law saying that it was produced because of your regional anesthesia. So that's why it is always, better properly examined and then documented, this peripheral neuropathy. So very important about that. Separately, you have CNS examination, this examination for mononeuropathy multiplex, or peripheral bilateral symmetrical neuropathy. So because it's important for us for our anesthesia purposes also. Okay, coming to now, this is about your history, and of course, you told about palm print sign. That is another thing, because I did not see in your this thing. You just verbally you told about that. Later, you must have remembered. So again, that becomes very important, because these patients are likely to have, especially chronic diabetics, likely to have airway problems for us, especially the temporomandibular joint or
Hospital joint.
joints, and even the cricoarytenoid joints. Even cricoarytenoid joints, they may not open up. The vocal cords may not open up. So if you think that he has got a stiff joint, it's also called a stiff joint syndrome. So if the patient has a stiff joint syndrome, you can know by your palm print sign or your prayer sign. Isn't it? So what is this prayer sign and palm print sign? Because we were discussing this. We will also for other listeners. What is this prayer sign?
In prayer sign, we ask the patient to approximate the palmar aspect of his both the hands, and we look
for aspect of which particular joint?
Interphalangeal joints.
Interphalangeal joint. That is more important. The interphalangeal joint. So these joints are more important.
Yes,
so approximate. Try to approximate. Then if he has stiff joint syndrome, he will not be able to approximate
the interphalangeal joints.
Interphalangeal joints. Then you go for palm print.
Palm print sign.
Yes, sir.
Okay. So in the palm print sign, you can grade it also. Grade 1, 2, 3. What is grade 1 palm print sign? How do you do this palm print sign?
So, sir, we'll ask the patient to paint the palm with ink and place the.
No, you are going to apply ink to the full surface of the palmar surface of the hand.
Yes,
and then you ask him to press it over a white sheet.
Solid sheet.
A solid sheet. He has to really press it. White sheet. And then you look at the, whatever that print you get because of this ink on his palmar surface of his hand. So once you see that image, so what you look for?
The interphalangeal.
You look for impression of the interphalangeal joint. Isn't it? So what is palm print sign 0?
All the interphalangeal joints are visible, sir.
Seen. Okay. Then 1.
The 4th and the 5th digit interphalangeal joints are not seen, sir.
Okay.
Grade 2 is the 2nd, 3rd, 4th, and 5th interphalangeal.
Second to fifth are not seen.
Not seen.
Okay. Then
grade 3, only the fingertips are seen, sir. No interphalangeal.
Fingertips are seen. Not a single interphalangeal joint. You will be able to visualize. So this is the palm print sign grade 3. So grade 3 means more the higher the grade, more severe will be the
airway difficulties.
Okay, so that's another very important sign you have to elicit. Okay, coming to just discussion about these patients with diabetes. So what is diabetes actually?
Diabetes is defined as a metabolic disorder characterized by hyperglycemia because of abnormal insulin deficiency or relative insulin deficiency, sir.
Okay, total insulin lack or relative insulin lack?
Relative insulin lack.
You can always say it is both a metabolic and an endocrinal. It need not be just because, it is dealt by majority of the times endocrinologists, isn't it? So it is both a metabolic and, pancreas, beta islet cells, actually they are endocrinal, isn't it? They do not have, basically they directly introduce this insulin into the blood without any ducts. So both a metabolic and endocrinal disorder actually characterized by hyperglycemia. Hyperglycemia is the basic thing. And it can be because of absolute lack or relative lack. Absolute lack means there can be insulin resistance at the peripheral. So how do you classify diabetes?
So there are type 1 diabetics and type 2 diabetics. The type 1 diabetic, it is early onset diabetic. That is, there is either autoimmune destruction of beta islet cells causing complete lack of absolute deficiency of insulin, sir.
Very good.
Or there is idiopathic type 1 diabetes, sir, where it is not autonomic, where it is not autoimmune, but the cause is not known. And in type 2 diabetic, it is usually a late onset diabetes, sir. It is caused by, it is associated with metabolic syndrome, and its predominant pathophysiology is the resistance to the insulin, sir.
At the peripheral tissues.
Yes, sir.
And also in the liver itself, in the liver and peripheral tissues. Okay. So age of onset of type 1 and type 2?
Listen.
Type 1, it is
Less
around
than 30 years of age. Type
No.
2 is more than 30 years of age.
40 years.
30.
More than 40, 50, usually more than 40 years. So 40 years can be cut off, but it need not be like that because, maturity onset diabetes of the young is also there, MODY, wherein even before 30, there's type 2 diabetes. Even children, we are finding type 2 diabetes is there. So for us, it's basically either insulin dependent or non-insulin dependent. That is very, very important. And one more thing about the type 1 is they are prone for what kind of a acute complication?
Diabetic ketoacidosis.
Yeah, whereas type 2,
Hyperosmolar
hyperglycemic.
coma.
they may not be, they may not go in for
Acidosis, ketone.
ketoacidosis. They do, of course, very rarely. They can also, when there is severe stress, when there is severe infections, myocardial infarctions, and such situation, they can even go for DKA, even type 2 diabetics, because there can be an absolute lack of insulin in such situations. Why, type 1 patients develop diabetic ketoacidosis? Why not type 2, usually?
In type 1, there is absolute lack of insulin, sir. Whereas in type 2, there is insulin production is there, but there is resistance in peripheral tissues. Even
So-
minimal amount of insulin can inhibit the production of ketone bodies, sir. So this
Ketone
causes
bodies are because of what, actually?
lipolysis.
Lipolysis,
Metabolism of lipolysis, sir.
isn't it? So lipolysis will release what kind of acids? Then directly it will not release the ketone bodies. Lipolysis will not produce ketone bodies directly. It produces free fatty acids, isn't it?
Beta oxidation via the
Lipolysis will release free fatty acids, and these free fatty acids again are converted into acetyl coenzyme A in the liver, and it is pushed for normal energy production. Whereas it has got a limiting factor. The liver cannot completely convert all these free fatty acids into acetyl coenzyme A. Once it is produced in so much of quantity, so then it will, instead of converting it into acetyl CoA, so it will be converting them into ketone bodies, isn't it? So that's how. And whereas the insulin has got two types of actions. One is the anabolic effect, and another is anti-catabolic effect. And you should also know that insulin is the only hormone in the body which is anabolic hormone. All other hormones are catabolic hormones. It's only anabolic. So it has got anabolic effects and anti-catabolic effects. Both are almost same, but anabolic is synthesis of many of like carbohydrate synthesis, protein synthesis, and all those things. Whereas anti-catabolic is preventing the breakdown. That is anti-catabolic. And for this anti-catabolic effect, the insulin requirement is a very small amount of insulin. If it is there in the blood, it is enough to prevent anti-catabolic effects. One of the anti-catabolic effect is lipolysis also. So in type 2 diabetics, there is enough insulin in the blood, actually excess insulin in the blood. So that is why these patients are not prone for diabetic ketosis. Whereas type 1, they're present with diabetic ketosis. Many times they would not have been diagnosed with diabetes, and suddenly they may develop a DKA, and then they present with this acute complication.
Yes, sir.
So that is why, as you have written, the difference, when the type 1 diabetics, usually the diagnosis is very early because they're present with this acute complication. Type 2, you cannot, they may have diabetes for the past 5 years, 6 years, and it is always an incidental diagnosis. That is what you have also written. This patient went for something else and he was found to be diabetic. It is majority, it is incidental diagnosis. So you will not know since how long the patient was diabetic or he had a intolerant glucose metabolism before.
Yes.
So that's another very important thing. What about the concordance rate of type 1 and type 2? What is concordance rate?
Insulin requirement.
No, concordance rate is, suppose if the two identical twins are there, so if one of the twin develops the disease, the other twin also developing the disease, then you say concordance rate is 100%. Okay, so if one twin developing the disease, other twin not developing the disease, the concordance rate is 50%. Type 2 diabetes, concordance rate is 100% because it runs in families. And even one twin developing, other twin also will be developing. Whether type 1, because it may be an autoimmune or the idiopathic, so its concordance rate is only 50%. Okay. And again, type 2 can be managed by either diet alone and exercise or may require oral hypoglycemics. Yeah, whereas type 1 always require
Insulin.
So why I went in for details about the difference between type 1 and type 2, invariably you'll be asked. And it is very important for us to differentiate type 1 and type 2 because management-wise, glycemic status intraoperatively depends on whether the patient is insulin dependent or non-insulin dependent. That's how you have to know. And again, type 2, whether the patients are requiring insulin, because later stages, what will happen is their beta cells will get destroyed, even in type 2 diabetics. Later on in their life, chronic diabetics, type 2 diabetics, they'll not be able to have the control of their blood sugars with only oral hypoglycemia. They do require insulin. Then, the management of these patients, again, like insulin-dependent diabetics. That is why this history, whether the patient does he require insulin also for control of his diabetes, is very important when you are asking about what medications the patient is taking. We'll have to ask about whether the patient is on insulin. Not that, this patient, when he comes to the hospital, if he is been put on insulin, it is not insulin dependency.
Yes, sir.
So insulin dependency is even otherwise also require insulin for the control of blood sugars. Type 2 also can later, exhaustion of the pancreatic beta islet cells can occur. So that you should always ask about. Okay, the other thing is the duration of diabetes becomes very important. Why the duration of diabetes is important?
Because
Longer duration,
patient may develop complications.
macrovascular
Yeah, longer the duration, the more chances of complications. One. So when usually the nephropathy develops, after how many years? Usually the microalbuminuria will develop.
15 years.
10 to 15 years.
Usually 10 years, microalbuminuria. So frank albuminuria and rise of creatinine will occur anywhere between 10 to 15 years. So that is why, that, okay, the patient is having diabetes for the past so many years. You know that this patient definitely may have a nephropathy as well. And that becomes a very important thing for us because most of these patients who come for even kidney transplant, almost you can say 40% of the kidney transplants are being done for diabetic nephropathy. That is another thing about the duration. One more thing is the chronological age and biological age. This is again you'll be asked about. In diabetics, it is very commonly asked in diabetics. What is chronological age and what is biological age?
Chronological age is the actual age of the patient, sir.
Yeah, depending on the date of birth.
Yes.
That is the chronological age, depending on the date of birth. Okay, what about biological age?
This is due to the diabetes, their aging is accelerated. Sir. Atherosclerosis and
biological age is the age of the tissues, different tissues. That is biological age. It need not be dependent on chronological age. Biological age is actual aging process of the tissues of the body. So actually in diabetics, it is hastened. It depends on whether they have got good control or poor control. So what will be the biological age in a type 1 diabetes if he is poorly controlled? For every year of his chronological age, how much extra aging will be occurring? Biological age. So for every 1 year of chronological age, they age by 1.75 years. That will be actual biological age. And we are interested in biological age or chronological age?
Biological age.
Biological age, isn't it? So that is why we have to know whether they have got a good control or a poor control And so since how long they are diabetic. For example, let us say a 40-year-old diabetic patient is there, type 1, and diabetes was detected when he was 20-year-old, type 1. So 20 years is there, poorly controlled. Actual age will be what? For every year after detection, so he'll age by 1.5 years.
Yes, sir. 30 years.
So 20 multiplied by now is already 40 years now.
Yes, sir.
What will be his age? Present
55 years.
55 years.
15 years should have been.
Plus added
20 by 1.75.
Yes, sir.
Isn't it?
35.
So another extra you have to add 20 multiplied by 0.75, you have to add to his 40 years. So roughly another 15 years, isn't it?
Yes, sir.
So you have to consider him as 55-year-old, not 40 years old.
Yes.
Okay. So if he has got very good control, type 1, still he ages by 1.5 years for every year of his chronological age. That is reason, the type 1 diabetics age faster. Whereas type 2 diabetics, for every year of their diabetic, the detection of diabetes, so they age by 1.5 years if it is poorly controlled. And if it is well controlled, they age just by 1.03 years. Hardly they'll age much if it is very well controlled. That is why, it is very important about the duration of diabetes and whether they have got good control or not. And by that, whether what is their biological age. And it is irrespective of the chronological age. So that is another very important thing about the duration of diabetes. And how do you classify the complications of diabetes? Invariably, they do develop complications.
Yes, sir.
How do you classify them and what
Sir,
are these?
acute and chronic complications, sir.
Okay.
Acute is diabetic ketoacidosis, hypoglycemic state, and hypoglycemia, sir.
Hypoglycemia. Okay.
Yes,
There
sir.
are
Chronic
okay.
Chronic is microvascular complications and macrovascular complications, sir. In
Okay.
microvascular, diabetic nephropathy, diabetic neuropathy, and diabetic retinopathy, sir.
Okay.
And macrovascular is CVA, myocardial infarction, and peripheral vasculitis, sir.
No, you can say coronary artery disease, cerebrovascular disease, peripheral vascular disease. Isn't
Yes,
it? And coronary artery disease and peripheral vascular disease can be hypertension also.
Yes.
Isn't it? And another very important thing, when you are examining for peripheral vascular disease, you have to examine for all the pulses. And because, there may be absent pulses also because of the peripheral vascular disease. So it's very important for us to know. Suppose if right radial is not there, if you have not examined, after giving spinal anesthesia, you are trying to palpate the right radial, then there won't be any pulse. Then you may think that, the arrest has occurred, isn't it? So it's very important to, feel for all the peripheral pulses and then note down in your examination findings. So coming to the, you said about the autonomic neuropathy, invariably you will be asked about autonomic neuropathy tests. That is called as cardiac autonomic neuropathy test, CAN test. And it was introduced by Clark and Ewing in 1977. It was introduced, modified again in 1999. Slight modification was there. So these are autonomic neuropathy tests, and invariably you will be asked. Not that every one of you will be asked, but it is very common to ask because it has got a high relevance for us for managing these patients if they do have autonomic neuropathy. Already we have discussed. So what are the tests for parasympathetic first and then sympathetic later?
For parasympathetic, there is a heart rate variability test, sir. During inspiration and expiration.
Heart rate variability for deep breathing.
Deep breathing, yes, sir.
So you always say heart rate variability for deep breathing. That is the first test you also do. And how do you do this?
So we ask the patient to take slow, deep breaths, sir.
How many breaths per minute?
To take six breaths per minute, sir.
6 breaths.
Each breath lasting for 10 seconds, inspiration for 5 seconds, and expiration for 5 seconds, sir.
Why 6 breaths? Why not 3 breaths? Why not 12 breaths? Why not 10 breaths? So you see, these are tests were done by Ewing and Clark. isn't it? So they studied thousands of people and with different respiratory rates. They found maximum variation with 6 breaths per minute. That is why, the 6 breaths is always indicated. Okay. So before that, what you should do for the patient? You recommend something?
We'll attach a ECG.
Yeah, a continuous ECG monitoring has to be done.
Yes.
Continuous ECG monitoring, and you have to repeat this test for three times. 3 times you will have to repeat and see whatever the maximum RR interval and then the minimum RR interval, and you calculate the heart rate with that. What should be the difference of the heart rate during maximum expiration and maximum inspiration? Inspiration heart rate increases or decreases?
With inspiration, heart rate increases.
Yeah, why it increases?
During inspiration, there is increased blood pooling in the pulmonary vasculature, sir. So the
increased venous return. You should say increased venous return.
Yes, sir.
So increased blood in the right heart. So it has to be pushed into the left heart and also into the systemic circulation.
Yes, sir.
Doesn't have to hold that increased amount of blood in the heart. That is why there is increase in the heart rate.
Yes,
So this is a parasympathetic activity. So based on the baroreceptor activity, so there is increase in heart rate. So during deep expiration, there is decrease in heart rate. This is almost like a sinus arrhythmia. This is a sinus arrhythmia. And normally when the patient is taking this kind of a deep breaths, in normal patients, how many difference will be there?
More than 15.
15 breaths difference has to be there. And when you say autonomic neuropathy,
less than 10 beats difference.
Less than 10 breaths per minute, you call it as autonomic. Okay, one is the heart rate variability for deep breathing. Second is?
Sir, Valsalva maneuver, sir.
Heart rate variability for Valsalva maneuver.
Yes,
how
sir.
it is done? How Valsalva maneuver is done? You require any equipment?
Yes, sir. Sir, we'll ask the...
No, do you require any equipment other than your ECG monitor?
Yes, sir.
The patient has to blow against resistance of 40
mm, sir.
So you should have a instrument with a manometer.
Yes, sir.
And also it should have only a valve which can allow for inspiration, which should not allow for expiration.
Expiration.
It should close during expiration, isn't it? So patient takes a deep breath and then tries to expire.
Yes, sir.
And then holds it, isn't it, with a pressure of 40 millimeters of mercury.
Yes, sir.
So now you will be continuously recording the ECG. How many phases are there in this usually?
4 phases, sir.
4 phases. What is the first phase?
Sir, during first phase, there is a decrease in heart rate, sir.
This is when he holds the breath. That means he is increasing his intrathoracic pressure.
Yes, sir.
So what happens to the heart rate now?
Decreases in the heart rate, sir.
Why heart rate decreases?
Because of increase in intrathoracic pressure and due to aortic compression, there is a flow of blood from the central circulation to peripheral circulation. So
suddenly there is increased blood flow to the peripheries. Yes, from the thorax, because the aorta gets compressed. Sudden increase in the intrathoracic pressure compresses the aorta, pushes the blood from central circulation to peripheral circulation. The blood pressure increases
and heart rate decreases.
There is heart rate decreases. Okay.
Yes,
this case, patient is continuing to hold the breath in the second.
Continue to hold the breath. So there is because increase intracranial intrathoracic pressure, venous return will decrease, sir.
Very good.
So there is a fall in BP and a reflex tachycardia will be there, sir.
Tachycardia will occur. Very good. So second phase, actually there is increase in heart rate. First phase, there is decrease in heart rate. Second phase, there is increase in heart rate. What happens to third phase? He suddenly is releasing the pressure.
Yes, sir.
He takes a breath. What happens now?
So there is. So at the end of expiration, there is still more fall in blood pressure and increases in the heart rate, sir.
Because there is a brief, milliseconds in which, though the intrathoracic pressure has come down, there won't be immediately venous return will not occur.
Yes, sir.
It will take a little bit time. So because further fall of blood pressure occurs, so there is further increase in the heart rate. So there can be a maximum increase in the heart rate in phase 2 or phase 3.
Yes, sir.
So after that, now in the phase 4, suddenly there is a maximum amount of venous return will occur, and there will be an overshoot of blood pressure.
Yes, sir.
And because of that, bradycardia occurs.
Yes, sir. Bradycardia, sir.
So maximum decrease in the heart rate can occur in the phase 4. Maximum increase in the heart rate can occur in phase 2.
Phase 2.
So you take a ratio of this.
Phase 4 and phase 2, sir.
RR intervals of phase
4 and phase 2.
4 to phase 2 or phase 3, which is the maximum decrease in either 2 or 3. So it should be more than normally
1.2.
No.
More than 1.2. It should be more than 1.2. So if it is less than 1.1 or less than 1, then you consider it as significant to have autonomic neuropathy. Okay, then the third test is standing test, isn't it? So what is the standing test? The heart rate variation for standing.
Yes, sir. So when we ask the patient from lying supine to stand, sir.
No, first you record the ECG
heart rate
down.
Yes, sir.
And make the patient to stand.
Yes, sir.
And we continue to record his ECG.
Yes, sir. So there will be sudden hypotension, sir, for which there will be a reflex tachycardia.
No, venous return will not be immediate, isn't it?
Yes,
so because of the autonomic neuropathy, venous return cannot occur. So you are recording the the ECG. So initially there will be tachycardia.
Yes, sir.
Normally also initially
Yes.
tachycardia. And later,
It
increasing the sympathetic activity, venous tone increases. So the venous return will increase and the heart rate will come down.
Yes, sir.
So this is usually maximum increase in the heart rate occurs by
maximum increase occurs by 15 seconds, sir. And by 30,
not 15 seconds, 15th beat.
15th beat, yes.
Yeah. And maximum decrease in the heart rate occurs by 30th beat.
30th.
The compensatory effects would have occurred.
Yes,
so you take the RR interval, isn't it? But there was a controversy which should take RR interval between 14th and 15th beat or 15th and 16th beat or 29th and 30th beat or 30th and 31st beat. So that's why, they modified it again in 1990. This is the only modification. So is in the first 15 beats, you take the narrowest RR interval. And after from 16 beat to 30th beat, you take the widest RR interval. And you get the ratio between the widest RR to narrowest RR. And it should be normally it is more than
1.04.
1.04. Normally it is more than 1.04. It can be less than 1, isn't it? To say significant autonomic neuropathy. So this is again heart rate variation to standing. Then now these are the three parasympathetic tests. Now the sympathetic nervous system tests. One is standing test, that is recording blood pressure in the lying down and standing.
Standing, sir.
Yeah, standing, after how many minutes you will take the blood pressure?
2 minutes.
You will give 3 minutes.
Okay.
So 3 minutes to compensate, and then only you record the pressure. And normally the difference of systolic pressure in supine and standing should not be more than
30 millimeters of mercury, sir.
Normally it should not be more than 10 millimeters.
10, sir. Normal 10.
Yeah, in these patients it can be as high as more than 30 millimeters.
30 millimeters of mercury, sir.
Okay, that is another test. And then the last test is the hand grip, sustained hand grip test. So for this, what you require? What instrument you require?
BP monitor.
Dynamometer.
Yeah, you require a dynamometer. Require a dynamometer. So how it is done is you ask the patient to maximally press the dynamometer, isn't it? And you get this amount, a particular amount of pressure he can create by maximally, gripping this and then applying pressure. So then he has to reduce it to 30% of the maximum and sustain it for 3 to 5 minutes. And you are going to record the blood pressure during this particular time. Before the test, you are recording the pressure, and when he is having sustained hand grip, you are going to check the diastolic pressure here. Which limb you are testing? Which upper limb?
Opposite limb, sir.
Not the same limb where he is applying the pressure. So what should be, when do you say it is significant?
The diastolic blood pressure should have been increased by 16 millimeters of mercury.
More than 15, yes. So any decrease in blood pressure or increase not more than 10 millimeters, you consider it as significant. So these tests are very important. Autonomic neuropathy tests by Clark and Ewing. Invariably, you may be asked about these tests. So just remember about these tests. Okay, so that's about the examination things. And now this patient is posted for, and also you should know about the macroangiopathic lesions, like whether the patient also has got CVA. If the in the history only you'll have to ask, because again that is very important. If the patient has had a stroke, so you'll have additional medications. And again, if the patient has had a stroke, it is better not to take up for elective procedures, ideally within 3 to 4 months, because there will be a lot of disturbance in his autoregulation in the brain. So he can go for reinfarction rate is very high if these patients with CVA are taken up within 1 month of the CVA. So you'll have to, ideally, what they have found is 11 months, they have found after 11 months, the reinfarction rate is not much. It is same as a patient not having a CVA. So that is why they say that ideal would be 11 months, or at least about 3 or 4 months you have to wait, because it takes about more than 3 months for autoregulation to recover. So that is another very important thing, CVA, because of macrovascular complications. Okay. So now this patient is posted for, let us say, has been posted for wound debridement. So now how do you investigate him, and how do you manage him?
Sir, we'll ask routine investigations, sir.
Okay. So
Complete blood count, hemoglobin.
So hemoglobin can be decreased in these patients?
In case of a peripheral vascular disease, the hemoglobin will be
Not peripheral vascular disease. If they has got nephropathy.
Sir.
Because you know that the kidney. Yeah. Erythropoietin is secreted by the kidney.
Kidney, sir.
Chronic kidney disease patients will have severe anemia. So that's why these patients may have chronic kidney disease. Don't know. They may not even know about it. So hemoglobin estimation becomes very important. Okay. Then
total counts.
Yeah, because this patient already has got an infection.
So
I would like to see what is this. He might even develop septicemia. And they are prone for septicemia, diabetic patients, because the immunosuppression. So that is why you just look for what is the total leukocyte count. Okay.
platelet count, sir.
Pardon?
Platelet count.
Yeah, platelet count. Okay.
Then we'll ask for renal function test, sir.
The urine examination, isn't it? Urine examination is very important, because I told you that even type 2 diabetics can develop diabetic ketoacidosis. It is not that they won't develop if they are, having severe stress, either physical or emotional stress, especially like myocardial infarction if they develop, or if they have severe infections, and they definitely can go in for DKA, and even emotional stress. So that's why you have to rule out ketosis by doing a simple urine examination for ketone bodies. So what is the older test for ketone bodies that was done for in the urine?
Urinary dipstick test, sir. Dipstick.
No. Older one, which may be asked for you in the exam. Many of the examiners would have done it. Rothera's test.
Rothera's test.
Yeah, how do you how do you know that it is supersaturated? Is that you keep on adding ammonium sulfate crystals and keep shaking, so it starts dissolving, and after some time there won't be further dissolving of ammonium sulfate will not occur. There will be residual crystals of ammonium sulfate can be seen at the bottom of the urine test tube. So then you know that you have supersaturated the test tube, the urine with ammonium sulfate. To this, gently, without shaking, you have to add liquor ammonia from the sides. And also, after adding a small amount of liquor ammonia, you add a small amount of sodium nitroprusside from the sides. So development of a purple ring at the junction of all these three in the top, you say that the patient has ketone bodies. That was the routine test that was being done in the olden days, Rothera's test. So
Yes,
it
sir.
may be for you. So now what we do is a drip stick. So
Drip stick test.
sticks. With that you can know. What are the common ketone bodies?
Sir, acetone, acetoacetate, beta hydroxybutyric, sir.
Yeah, beta-hydroxybutyric acid. So out of them, which one is not excreted through the kidneys into the urine?
Acetone.
Acetone, sir.
It's beta-hydroxybutyric.
Beta-hydroxybutyric.
So when you are examining the urine, you will be examining for only acetone and acetoacetate.
Acetoacetate.
You will not be examining for only way of examining is the blood ketone bodies. Then separately, there are now laboratory they specifically look for beta-hydroxybutyrate. So that is beta-hydroxybutyrate. Quantity is analyzed in many of the laboratories. So it becomes more important, and because that is the one which actually produces the metabolic acidosis in these patients. And what is the half-life of these things in the blood? Acetone, acetoacetic acid, and beta-hydroxybutyric acid. Which is the shortest half-life, or whatever you can call it as?
Acetone and acetoacetate as shortest half-life, sir.
They are talking about the opposite. It is a beta-hydroxybutyrate can stay in the blood for only about 4 to 6 hours. Whereas acetone can remain even for 48 hours. And acetoacetic acid is about 18 to 24 hours. So why it's important is, even though when you start treating, the patient might have been treated well, because beta-hydroxybutyrate is most important. So immediately once you start treating, the beta-hydroxybutyrate levels will start coming down. And once it is cleared, the blood is cleared from beta-hydroxybutyrate, the patient is almost becomes treated. But he may still continue to excrete acetoacetic acid and acetone. So acetone is excreted by kidneys and through what else?
Lungs.
Each other organ, lungs. That is why acetone produces that sweet odor.
Yes, sir.
Of these patients with diabetic ketoacidosis, isn't it? So that is why you go for delta gap in the ABG to know exactly whether they have been treated well or not. So invariably, you will be asked about diabetic ketoacidosis management also. That we will discuss when we discuss about patient coming for urgent surgery, or in emergency surgery.
Is more than 200 milligrams per deciliter.
Okay.
And HbA1c is more than 6.5, sir.
Yeah, that is there. Okay. So you want to get these tests done for these patients also. Why do you want to get these tests done, though you know that these patients are diabetic already? Why you want to have this test done?
So now patient
the control of diabetes.
Yeah, to know the control, and especially HbA1c, isn't it? So why HbA1c is important?
It is the glycosylated hemoglobin level, sir. So we'll be able, since the duration of half-life of RBCs is 120 days, we'll be able to know the average
3 months.
3 months
Glycemic control of the patient.
Okay, let us say that it is 11.
It is very poorly controlled.
Poorly controlled. So what? So what? Suppose this patient is being posted for an elective major surgery with HbA1c 11. Should I take him up or should I postpone the surgery?
You should postpone the surgery, sir.
Because what has been found in many of the textbooks say that if it is a major elective surgery like CABG or any other surgeries, if the patient has got a HbA1c of some books say more than 8.5, some books say more than 10. It is better to control and then take up, because what has been found is the postoperative morbidity and also even the mortality is very high. These patients, if they have a poor control of diabetes state. So if it is more than 10, becomes very important. The longer the duration of diabetes, nephropathy are very common. So you have to get a serum creatinine done, and you can estimate the GFR also. eGFR also you can. So other tests like fractional excretion of sodium, if the patient has the nephropathy, you can definitely do all those tests of renal functions. Okay, any other tests you would like to do before taking up?
Serum electrolytes.
Serum electrolytes becomes very, very important. So why serum electrolytes are very important? Why they can...
The potassium values are important, especially if you want to start the insulin.
Insulin correction will...
Yeah. Suppose if the patient is on insulin, what happens to potassium?
There is a shift of potassium, intracellular shift of potassium, sir.
Yeah, shifting of...
Which may result in hypokalemia.
Yeah, that is always there. That is why, potassium variations can occur. So it is always better to have a basal potassium levels. And if the patient has diabetic ketoacidosis, there can be, again, variation in the potassium levels, depending on whether you have started treatment or you have not started treatment. So that is why serum electrolytes are very important. One more thing is many of these patients may be, having nephropathy. And again, chronic kidney disease, that there can be hyperkalemia. And another thing is if they also have a diabetic ketoacidosis, hyperkalemia is very, very common. Okay, so serum electrolytes, fine. Then what other investigations?
ABG can...
Yeah, you can have an ABG, definitely. Especially if you suspect diabetic ketoacidosis, ABG becomes very important. Okay, so these are the investigations you have done now for this patient. Now, what are your goals as far as in taking up this particular patient for surgery and anesthesia? What anesthesia goals, what surgical goals?
The anesthetic goals will be to avoid hypoglycemia, sir. And,
avoid strictly hypoglycemia. You have to avoid. Yes, very good. Then
to prevent hyperglycemia and hypoglycemia.
What hyperglycemia? Suppose the blood sugar is 160. You call it as hyperglycemia in these patients?
No, sir. We can accept a blood sugar of 140 to 180.
180 milligrams.
But that's why you say that avoid hypoglycemia by any means. Hypoglycemia is a killer. It is very dangerous. Second thing is avoid excessive hyperglycemia. When do you say it is excessive hyperglycemia?
When it is more than 200 milligrams per day.
More than 180, you can excessive hyperglycemia. You do not allow it to go beyond 180 or 200. So that is why your second goal is to avoid Excessive hyperglycemia. Okay. What is your third goal?
To prevent hypokalemia.
To prevent?
Dyslipidemia.
To
Hypokalemia.
prevent ketosis. That becomes very important. To prevent intraoperative and postoperative ketosis. And why ketosis? Type 1 are definitely prone for ketosis. If you do not give them insulin, they'll definitely go for ketosis because, anesthesia is stress, surgery is stress. So if you stop giving them insulin in the perioperative period, they'll go for ketosis, isn't it? The second thing is, these diabetics always require glucose. Otherwise, they'll go for hypoglycemia and also starvation ketosis. Starvation ketosis is also very common. If you don't give them glucose, they'll go for other means of producing glucose. Especially lipolysis is one of the common, neoglucogenesis. So they'll go for starvation ketosis. So you have to avoid whether it is starvation ketosis or whether it is diabetic ketoacidosis, you'll have to prevent. So that is your third goal. So, okay, what is your fourth goal? You have to maintain strict asepsis. Whatever you do, whatever the procedure, even probably by placing an IV line, you have to wear sterile gloves and then place an IV line. So you have to, because these patients have immunosuppression, you have to take absolute precautions in order to prevent any infections.
Yes, sir.
Okay, then what other precautions you will be taking? These patients may have mononeuropathy multiplex, peripheral neuropathy. So what it can produce? So especially I'll give you a clue, like pressure areas.
Yes, sir. Adequate padding.
Yeah, adequate padding has to be done for pressure areas because they are highly prone for, ischemic
Nerve
injuries,
Yes, sir.
nerve injuries or ischemic injuries, even, bed sores also very common. They can develop because as such, there is a decreased circulation as far as the nerves are concerned. So actually better you have to maintain adequate padding. Then next goal.
We have to be very careful while changing positions, sir, during
Positioning.
surgery. They
Positioning.
might develop sudden hypertension.
Yeah, if they have autonomic neuropathy. Yes. Then one more, we were discussed about our sudomotor problems of autonomic neuropathy. What you have to be
Temperature
Sir,
regulation.
temperature monitoring, sir.
Yeah, you have to be
Temperature
extremely careful because they are highly prone for hypothermia. So you have to maintain normothermia throughout, isn't it? And what else?
And we
So
have to
they are
avoid post-operative pain, sir. So that,
no, they are again prone for hypoglycemia and hyperglycemia intraoperatively. So monitoring of the blood glucose.
EBG monitoring.
You have to continuously monitor the blood glucose. Every hourly monitoring is very important. And adequate hemodynamic monitoring also because they are highly prone for refractory, hypotension and refractory bradycardia. And this is very common if they have autonomic neuropathy.
yes.
If they have autonomic neuropathy, they can have, even positional changes can produce refractory hypotension, and your spinal anesthesia can produce severe refractory hypotension and refractory bradycardia. And even your IV anesthetic agents or inhalation anesthetic agents can also produce the same problem. Refractory means refractory to routine vascular. You may have to keep ready your diluted adrenaline or epinephrine, and you may have to use it because they'll be refractory. Their heart rate and blood pressure will be refractory for these things. Severe hypotension, severe bradycardia can occur. So that is another very important thing. So continuous monitoring, vigilant monitoring is very important. So these are some of the goals. So with these goals, so now coming to the glycemic control. That is the most important thing when compared to the type of anesthesia. The other important thing when compared to a non-diabetics, here additional thing whenever you have a diabetic patient is their glycemic status monitoring and then maintenance. How do you manage their glycemic control? So again, for this, you have to divide the surgical technique as minor and major. And again, type of diabetics, whether they are insulin dependent or non-insulin dependent. And 90 to 95% of your patients are non-insulin dependent patients, isn't it? Because insulin dependent diabetes is only 5%. But many of these type 2 diabetics can be on insulin. So they should be considered as they are insulin dependent only while managing the glycemic status. So there are many regimes are there, isn't it? So many of the students are invariably get confused with these regimes. What kind of a regime that has to be used for maintaining glycemic status in these patients? There are some certain older regimes are there. Now they are not being followed, with the modern regimes are slightly different. Okay, so basically they are considered as in the older regimes, and even now also, what do we call this, broadly classify these regimes of maintaining glycemic status? Tight control, non-tight control.
Non-tight control.
Yes, sir.
They were classified like that. Tight control regime, non-tight control. What is this tight control regime?
Tight control regime, we have a target sugars between 80 and 120 milligrams per deciliter.
80 to 110.
110.
Yeah. 80 to 110, you maintain in that a small range of blood sugars, 80 to 110. That is tightly you are controlling the blood sugars. Whereas non-tight control regime?
Sir, 140 to 180.
From 110 to 180, you can say.
Yes, sir.
80 to 110 was tight control. 110 to 180 is non-tight control regime,
Non-tight control, sir.
isn't it? So now which regime we follow?
Non-tight control.
Non-tight control.
Why this tight control regime we are not at all following?
Because patient may go for hypoglycemia, sir. That is
Incidence of hypoglycemia is very high with tight control. That is why, initially maybe about 15 years or 20 years back, we used to say that tight control regime ideal to be for all those type 1 diabetics and pregnant women and, trauma patients, and also in ICU patients, the critically ill patients, and patients posted for cardiac or neurosurgery. So these 5 group of patients, we used to say indications for tight control regime. But later they found out that, the incidence of hypoglycemia is so high in all these patients. And also when they went in for non-tight control regime, the morbidity and mortality was same, whether you go for tight control or non-tight control regime. But the more incidence of hypoglycemia in tight control regime. That is why, you better not to go for tight control regime. Always nowadays, our goal as far as glycemic status is concerned is ideally above 110, below 180. So the complication rate is very, very low, especially hypoglycemia. So that will be our main aim to manage. Okay, now a patient with type 2 diabetes maintained on, on diet therapy or oral hypoglycemics, posted for minor surgery. How do you classify this minor or a major surgery in these patients?
Minor surgery is when the patient will not need to skip the next dose of oral hypoglycemics.
No, that may be one of the definitions, probably. But usually when we say tight control, the minor surgeries is the surgeries do not last more than 2 hours. One. The second thing is, they can revert back to their regular diet as early as possible. In the post-operative period. So if they can revert back to their regular diet in the post-operative period, you need not have to change their whatever the hypoglycemic drugs they are on, isn't it? So you can just continue the same drug. That is what is the minor surgery. Whether it is for insulin dependent, non-insulin dependent, minor surgery is same. And major surgery is where you expect the surgery to be prolonged for more than 4 hours. And second thing is, there is a lot of major shifts of fluids intraoperatively and expect the same thing in the postoperative period. And these patients will not be able to take their regular diet for more than 24 hours. That is called as a major surgery. So that is how, you will be asked, what do you mean by a minor surgery or a major surgery in a diabetic patient? So, okay. Now, for a patient who is on type 2 diabetes, strictly like our patient here, if he is posted for a minor surgery, for example, now this surgery is posted for like wound debridement. Do you think it is a minor surgery or a major surgery?
Minor surgery, sir.
For example, if he is posted for a below knee or above knee amputation.
That would also be considered minor surgery.
Because it can be done within 2 hours.
2 hours, yes, sir.
And the patient will be able to.
Patient can resume his diet
Right.
pretty early, within 2-3 hours after the completion of the surgery. It can be still considered as a minor surgery, but you have to give GA, and it's a major abdominal surgery, or even renal transplant surgery, any transplant surgeries. All these are actually major surgeries. Okay, now this patient is on not on insulin, he's on oral hypoglycemic agents and posted for a minor surgery. So how do we manage? And before that, let me ask you, because I was looking at the time, another 20 minutes is there, but it is very important to know about classification of this oral hypoglycemics and also classification of insulin. So briefly, you tell about the classification of these drugs, and also to know whether to continue these drugs or not to continue these drugs the previous day and the day of surgery. So it becomes very, very important. So let us just discuss about these oral hypoglycemics. How do you classify these oral hypoglycemics?
Sir, we will classify as a insulin secretors, insulin
Secretagogue.
Yes, sir. Secretagogue.
Yeah, secretagogues. Then
insulin sensitizers.
Sensitizers. Okay, then
alpha glucosidase inhibitors.
Okay, so which decreases the absorption of glucose from the GI tract.
Yes, sir.
Alpha. Drugs which decreases the absorption of glucose or carbohydrates from the GI tract. Okay. Then the fourth,
increase glucose excretions.
Yeah, through the urine.
Yes, sir.
Which increases the urinary excretion. So what are these?
Yes.
This SGLT is the one which is very important in the proximal convoluted tubule for absorption of glucose, whatever that is, secreted or through the glomeruli comes into the proximal convoluted tubule. So it is reabsorbed by this SGLT2. So if we inhibit this SGLT2, that is sodium glucose transporter, co-transporter. If we inhibit sodium glucose co-transporter, then glucose will not be reabsorbed, and it will be there excreted through urine. Normally up to 180 milligrams, whatever that is filtered by the kidneys is reabsorbed by the proximal convoluted tubules. It is only when it is more than 180, then only it is excreted through urine. But here, once the patient is on SGLT2 inhibitors, so even if it is less also, even normoglycemia also, they start excreting the sugars from the kidneys because there is hardly any reabsorption. So that's how, one of the methods of decreasing the blood glucose levels, isn't it? So SGLT2 inhibitors, okay. Individual drugs we'll discuss, and then classification. So incretin mimetics.
Yes, sir. Glucagon.
So what are these incretin mimetics? How do you classify them?
They decrease the metabolism of GLP, sir. Glucose-like proteins.
That is what is called as incretin also.
Sir.
Incretin is same as GLP. So one is GLP-1 agonist, isn't it? Another is
DPP-4 inhibitors.
Yes.
Normally, the basic physiology is whenever a carbohydrate enters into the intestines, the intestine cells will secrete incretin or GLP-1. So this GLP will act on GLP-1 receptors, and that is the one which increases the release of insulin from the beta islet cells and also decreases the glycogenolysis also from the liver. And also it decreases or increases the satiety so that, the patient will not have much appetite. So these are some of the, and also increases the peripheral sensitivity of insulin. So these are the four important functions of GLP-1. But this GLP-1 has got a very short duration of action, GLP. It has got a very short duration because it is, destroyed by DPP-4. Dipeptidyl peptidase will destroy the GLP. So now if you have DPP-4 inhibitors, then this GLP will continue to be effective. Listen, that is what the DPP-4 inhibitors will do. And GLP-1 agonists, they again, suppress the, destruction of the GLP, and also they directly will be acting on the GLP-1 receptors and produce the same effect as GLP. They can be even prolonged duration of action. Even GLP-1 agonists have been given once a week also. There are drugs with GLP-1. But only problem is majority of GLP-1 drugs have to be given parenterally. So they are not given orally. Now I think some GLP-1 drugs have been introduced which can be taken orally, but majority of them have to be given parenteral administration like insulin. Okay. So these are some of the, classification of oral hypoglycemics. And one more thing is, the insulin sensitizers you talked about.
Yes, sir.
Insulin secretagogues, again, you have sulfonylureas,
Yes, sir.
which are secretagogues, which increase the secretion of
Insulin.
And, insulin sensitizers, you have biguanides, that is metformin.
Metformin.
You have thiazolidinediones. These are insulin sensitizers, which actually increase the sensitivity of the insulin in the peripheral tissues and also decrease the glycogenolysis and also glucose neogenesis from the liver. That is the basic thing. And also metformin also acts as, decreasing the absorption of carbohydrates from the intestine. And also it, suppresses the appetite. There are multiple advantages of metformin, and recently metformin has been found to prolong the longevity. Many of the people who are not diabetics are also taking metformin in Western countries to increase the longevity because very cheap drug, time-tested drug, since ages it is being used. And if it can prolong the longevity, why not? That is the reason why a lot of people are on and taking this metformin. And the other thing we were talking about was alpha glucosidase inhibitors. Again, they inhibit the absorption of
Intestine.
carbohydrates from the intestine. But basic problem with metformin and alpha glucosidase inhibitors, because they decrease the absorption, there can be, dyspepsia, bloating sensation, increased flatulence. All these are some of the problems with both metformin and alpha glucosidase inhibitors. So the other DPP-4 inhibitors and GLP-1 agonists already we have talked about. Okay, now once the patients can be on any of these drugs, isn't it? So when you are going to stop these drugs, suppose the patient is on, which are the drugs which actually produce hypoglycemia for the patient if they are continuing?
Sulfonylureas and
Sulfonylureas, sir. And
so sulfonylureas are very dangerous. They can produce hypoglycemia, whereas all other drugs do not produce hypoglycemia. Whether it is metformin, whether it is thiazolidinediones, or whether it is alpha glucosidase inhibitors, DPP-4 inhibitors, or GLP-1 agonists, they do not produce hypoglycemia. That way they are safe. Okay, so sulfonylureas, when do you want to stop?
Ideally,
2
days prior.
2 days prior to surgery, sir.
But even 24 hours before is also okay. Why do you want 2 days before? Is there any particular reason?
Because metformin and glibenclamide, they are long-acting drugs.
No. We are talking about sulfonylureas.
So
glibenclamide is a long-acting.
No, it's intermediate acting, isn't it?
Intermediate acting.
Yeah.
Glipizide and glimepiride are long acting.
No, chlorpropamide.
Yes, sir. First generation.
Salbutamide and chlorpropamide were long acting.
Long acting.
Okay, so glibenclamide acts for 12 to 18 hours. So it is actually 24 hours is enough. But some people say that 2 days. Why 2 days? This is mainly for major surgeries. So why 2 days? It is because one thing that it has been found that they can block the potassium channels in the heart. So they can suppress the ischemic preconditioning of the heart. So the heart will become more vulnerable for ischemia if the patients are on, the sulfonylurea drugs. And intraoperatively, ischemia chances are very high, isn't it? Because this is there, hypotension can occur, tachycardia can occur. There can be a lot of problems as far as the demand-supply ratio. So that is why this 2 days, if you wait, so this ischemic preconditioning may return back. So the effect on potassium channels will not be there. That's why some people advocate to stop sulfonylureas at least 2 days before. But even 24 hours is enough as far as the hypoglycemia is concerned. Okay, then metformin.
Sir, 2 days.
No. Metformin can be continued till the previous day because it won't produce hypoglycemia. Only rarest complication of metformin is lactic acidosis.
Lactic acidosis.
And we have not seen, lactic acidosis at all. And you usually stop metformin if the patient is expected to develop, any renal problem intraoperatively, like acute renal injury, or if there is any contrast is being used intraoperatively, radio contrast is being used, then better to stop metformin the previous day itself. So that is about metformin. About alpha glucosidase inhibitors, like acarbose, valibose. So they don't have any role, isn't it? Because you're not giving any food to the patient intraoperatively. So it is better to stop acarbose, or they won't produce any effect at all. Because if you are giving orally something, then only carbohydrate, then only they are required to be used. Okay, then DPP4 inhibitors.
Gliptins.
Previous day we have
We'll use.
It again depends on major surgery or minor surgery. Minor surgery you can continue on the day of surgery also. That is what it is quite safe, DPP4 inhibitors. Major surgery you can stop on the day of surgery. Okay, SGLT2 inhibitors. What is the problem they can produce?
They can increase the risk for UTI.
Yeah, one is increased urinary tract infections, especially candidiasis is very high with patients on SGLT2. That is not the reason to stop or continue. What is the other complications they can produce?
Euglycemic ketoacidosis.
Euglycemic ketoacidosis is one of the complications that it can produce. That is, quite common. It can produce euglycemic because, it is excreting glucose. So there won't be any hyperglycemia, but still the patient can go in for ketoacidosis, isn't it? That is one problem. What is the other problem? Because glucose is being continuously excreted. Along with glucose, what else will be excreted out?
Water, sir.
Yeah, water and electrolytes.
Dehydration.
Yeah, patient is likely to develop dehydration and electrolyte imbalance if you continue SGLT2 inhibitors. That is why, many of the books will advocate that SGLT2 inhibitors should be stopped at least 24 hours, but ideally at least 2 to 3 days. 2 to 3 days before only you stop SGLT2 inhibitors. So that is very important. And now GLP-1, that is the last oral hypoglycemic. Sorry, not oral. It is given parenterally. When do you stop? Or you want to continue?
The previous day of surgery we can stop.
No, they are long acting. I told you even some GLP-1 are given once a week also. Why you should want to stop GLP-1? They are not producing any hypoglycemia. They only produce, stimulation of the pancreas to release insulin. if there is hyperglycemia. If there is no hyperglycemia, they won't release insulin again. That's why they don't produce any hypoglycemia as such.
Yes, sir.
So because, GLP-1 agonists, they can produce gastroparesis. They can delay the gastric emptying. That is why now GLP-1 drugs are being used for weight reduction. Because, they delay the gastric emptying. So early satiety they produce. People cannot eat much. So that's how, it is being used as one of the off-label use is being for weight reduction. Of course, now what is the problem for us with patient continuing GLP?
The gastric emptying is delayed.
Yeah, so we'll have
Risk of aspiration.
full stomach and risk of aspiration will be very high. So that's how, GLP-1 may have to be, depending on its half-life, what drug particular GLP-1 agonist is being used. It can be even stopped, say, 1 week before or 2 days before. Okay, depending on what type of surgery the patient is, going for. So now we'll have to discuss few things. One is about, classification of different insulins. And second thing is glycemic status management intraoperatively and type of anesthesia for these patients and management of DKA if they are posted for urgent surgery. So these 4 things, I think tomorrow in just half an hour, we'll finish it off. Then finish one more short case because it's just 5 minutes. I think there are some, few people have asked some doubts. We'll just see the.
Yes.
Hemavati has asked for give another one example, sir. I don't know what for.
Sir, the weight, the biological
Sir,
age, sir.
Chronological age and biological age.
Biological age and chronological age, I was telling you that, one more example she wanted. Okay, type 2 diabetic who is uncontrolled, who is now detected to have diabetes at the age of 50. Now he is 60. What is his biological age? He'll be aging 1.5 years for every 1 year after diagnosis.
Yes, sir. So his age will be 65
years.
Yeah, 65. So I think that will satisfy Dr. Hemavati. So Vaishnavi Rajan has asked something. How long after resolution of DKA or ketone body is still seen? So they can be seen even after 48 hours. And what is the anesthetic implication with respect to regional anesthesia? We will discuss tomorrow. We are discussing. Okay. Sadhana has asked something. What is the difference in specificity between lab tested blood sugars and the capillary blood glucose measurement? Which should be preferred on the morning of? Ideally, you go for venous blood glucose. What we draw, that is ideal because, the one is capillary blood sugars are estimated with your glucometers. The glucometers may not have been calibrated properly. One. Second thing is, it is as good as an arterial blood. What is the capillary blood glucose we estimate? There will be a difference of almost more than 5 to 10% difference of blood sugars will be there. It is better to, more accurate will be the venous blood glucose. That is why you always go for a venous blood glucose rather than, a CBG with your glucometer. So best would be, then you also draw a CBG so that you are calibrating that particular instrument of glucometer. So that if the venous blood glucose is this much, what will the capillary blood glucose? Because you are not going to use a venous blood glucose assessment in the perioperative period. You are going to assess the capillary blood because you are using a glucometer. So you should have that calibration done. So straight away you can do a calibration. You draw the blood for both and send the blood to the laboratory and get the blood glucose estimated. And also at the same time, you have done a capillary blood glucose estimated. So you know the difference. So that difference you can use it in the perioperative. So it's a very good question that has been asked. Okay, I think these are the 3 questions. Any other doubts you have for the discussion what we have today?
Sir,
Sir,
one
one more
more
question.
doubt in the chat box, sir. If the patient is posted for elective surgery with a very high HbA1c, how do we schedule the surgery? Do we have to wait for 3 months to repeat the HbA1c?
Yeah, that is what, that if it is a very major surgery which involves like major fluid shifts and all. So it is ideally speaking, you should start controlling the blood sugar, wait for 3 months, and then you should take up. It is an in ideal situations. Now, many times will not be an ideal situation. So it all depends on the pressures from the surgical side, and also, postponing surgery also may have all the problems of risks and benefits are also there. So we'll have to weigh all those things. And definitely, if the patient is uncontrolled with HbA1c very high, like 10, 12, and 13, he's likely to develop a lot of complications in the postoperative period. The morbidity definitely will be on the higher side, especially when the patient is posted for major surgery. So this, you have to talk to the surgeon, talk to the patient's attendants, and overall you will have to take a consent and then go for surgery. Because there are some studies also, they have found out that when the HbA1c was high, and intraoperative blood glucose has been very well controlled, and postoperatively also very good control of the blood sugars not going beyond 180, the mortality and morbidity was not high. There are studies have been done, and many of the studies say that it is always the preoperative and intraoperative blood glucose and perioperative blood glucose which is more important than HbA1c. There are a lot of controversies there. But you, for exam purpose, you just say that anything above 8.5, morbidity is high because the patient has not been properly controlled. But still, you can take up for surgery depending on the risk of postponement. Maybe much higher. And you can admit the patient for a few days. You can definitely control the blood sugars in 3-4 days. And because I told you that many of the studies have found out that the preoperative and perioperative blood glucose is much more important than the HbA1c. So you have to rely on your good control perioperative. That is why it's so important to have a good perioperative control of blood glucose. I hope you have understood.
Yes, sir.
Regarding HbA1c, isn't it? So, but you do get the HbA1c, but because you know whether patient has been very well controlled or not, but you give due respect to the HbA1c reports, and for discussing with the patient's attendants and the the surgeon. So you may have to postpone, say, for a few days, maybe about 3 or 4 days. Keep the patient inside the hospital, start proper control, and once the blood glucose is controlled, you can definitely take up the patient. I think one can wait for elective procedures. 3-4 days is not a too many delay of surgery.
Yes.
Okay, because there will be a lot of doubts regarding diabetes. So we'll extend our talk or discussion for a few more minutes. Tomorrow, maximum half an hour, 30 minutes. And on next case, we'll continue with the next case. What will be the next case?
TURP, sir.
TURP. Patient. Okay. So we'll finish it off. TURP we can finish off in just 1.5 hours. There won't be much problem. Okay then. We will also try to ask for more doubts. We can discuss briefly, and then we can go ahead afterwards.
Yes, sir.
Thank you so much. We will continue our discussion.
Thank you, sir.
Right. Yeah.